Urinary tract obstruction. So, the intrinsic or the extrinsic mechanical blockade, as well as from the functional defects not associated with the fixed occlusion of the urinary drainage system. Mechanical obstruction occur at any level of the urinary tract from within the renal tubules or the renal calcases to the external urethral meters. Obstructive uropathy. The normal points of narrowing which has a common sites of the obstruction are uteropelvic junction, uterovesical junction, bladder neck and the urethral meters. And the childhood causes are the congenital malformation, narrowing of the uteropelvic junction, abnormal insertion of the ureter into the bladder. Vesicoureteral reflex. If no UTI, bladder neck obstruction resolves with the age. If severe, reinsertion of the ureter into the bladder is indicated. May cause a prenatal hydronephrosis, can lead to the recurrent urinary infection, hypertension and the renal scarring in the childhood. Posterior urethral valves are the most common cause of the bilateral hydronephrosis in boys. For the acquired defects in the adulthood, pelvic tumors, calculi, urethral stricture. Ligation of the or injury to the ureter during the pelvic or the colonic surgery can lead to the hydronephrosis, which if unilateral may remain the undetected. Extrinsic neoplastic carcinoma of the cervix or the colon or the inflammatory disorders. Lymphomas, particularly follicular one and the pelvic or the colonic neoplasm with the retroperitoneal involvement. BPH 50% of women and aged greater than 40 years. For the functional impairment of the urine flow, voiding is altered by the abnormal pontine or the sacral centers of the micturition control. History of trauma, back injury, surgery, diabetes, neurologic or the psychiatric conditions and the medications. Causes include the neurogenic bladder, often with the adenemic ureter and the vesicoureteral reflex. Overflow urinary incontinence, sudden onset of the fecal incontinence, severe low back pain, and the saddle anesthesia requires the emergency evaluation for the possible quadra equina syndrome. So, the urinary retention of alpha adrenergic and the anticholinergic agents opiates. Hydronephrosis in the pregnancy. Relaxational effects of the progesterone on the smooth muscle of the renal pelvis as well as the ureter compression by the enlarged uterus, more often on the right side. Diagnostic tools, urinary flow measurements, post-void residual bladder volume ultrasound, cystourethroskopic and the urodynamic studies, assess the filling phase, cystometry, pressure volume relationship of the bladder, bladder compliance and the capacity, pressure flow analysis, bladder contractility and the bladder outlet resistance during the voiding. High pressures in the women, bladder obstruction, whereas in men, a diagnosis of the bladder outlet obstruction is based on the flow rate and a voiding pressure. A voiding cystourethrogram may be useful in evaluating the incomplete emptying in the bladder neck and the urethral pathology. For the flank pain, the surgery, this is the most commonly leads to the medical attention due to the distension of the collecting system or the renal capsule. Pain severity is influenced more by the rate at which the distension develops than by the degree of a distension. Flank pain that occurs only with the micturition is pathognomic of the vesicoureteral reflex, renal colic, little or the no pain, more insidious causes of the obstruction such as the chronic narrowing of the UPG. For the unexplained renal failure, insert the bladder catheter, diuresis, obstruction below the bladder neck, urologic evaluation. If there is no diuresis, no ultrasound, it may be either the hydronephrosis or we can do the CT scan to identify the site and the etiology of obstruction. Positive or the negative, but still high suspicion. Retrograde urography and the urethra is considered. Anterograde urography and the percutaneous nephrostomy is considered. If it is no hydronephrosis, high suspicion, low suspicion. For the low suspicion, there is no further workup for the obstruction. If it is the infection sepsis, requires the immediate relief of the obstruction, drainage by the nephrostomy, urethrostomy or the ureteral or the suprapubic catheterization, prolonged antibiotic treatment may be necessary. Chronic or the recurrent infections in the poorly functioning obstructed kidney may necessitate the nephrectomy. If there is no infection, acid base, fluid and the electrolyte status is nevertheless the site of obstruction should be ascertained as soon as the feasible. Elective relief of the obstruction, urinary retention, recurrent urinary tract infection, persistent pain, or the progressive loss of the renal function, VPH, alpha adrenergic blockers, and the 5 alpha reductase inhibitors. Renal colic, anti-inflammatory medication as a edema often contributes to an obstructing urethral stone, and the alpha adrenergic blockers may also be benefit. Risk of intraoperative floppy iris syndrome associated with the cataract surgery, alpha adrenergic blockers. Use of the NSAID, potential harm to the kidney, use with the caution. Functional obstruction secondary to the neurogenic bladder, frequent widening and the cholinergic drugs. For the prognosis, complete obstruction with the infection can lead to the total destruction of the kidney within the days. Partial return of the GFR may follow the relief of complete obstruction of 1 and 2 weeks of duration. After the 8 weeks of obstruction, recovery is unluckily. A renal radionuclide scan may be used to predict the reversibility of the renal dysfunction. Post-obstructive diuresis, massive polyuria, post-relief may contain the large amount of the initial phosphorus, phosphate and magnesium. Natriuresia, this is due to the correction of the ECV expansion, increase in the natriuretic factors accumulated during the period of renal failure. Depressed salt and water reabsorption when the urine flow is re-established. Osmotic diuresis, this is due to the retained urea is excreted with improved GFR. This increases the urine volume of the electrolyte free water hypotonic urine. Suppression of ADH at the atrial baroreceptor sites, elevation of the atrial peptides, nephrogenic diabetes insipidus due to the obstructive tubular injury. In the majority of patients, this diuresis results in the appropriate excretion of the excess of the retained salt and water. When ECV and the composure return to normal, the diuresis usually abates spontaneously. Replacement with the intravenous plays in the amount less than the urinary losses, except in the hypovolemia, hypertension or the disturbances in the serum electrolyte concentration. Replacement with the 0.45 saline is required.